Hi, everyone. Thanks so much for joining us on this third Thursday. I am excited to be speaking with you on a topic that is been, I think, overlooked and is resurfacing and needs a lot of attention, especially from clinicians currently. As we're battling a pandemic, many of our clients are also battling substance abuse, particularly opioid abuse, that is really troubling because we're not seeing them, we're not able to get to them. So today's discussion is going to be all about supporting those clients who are suffering from substance abuse. And we are in October, which is National Substance Abuse Month. So I am going to be joined by some amazing speakers, which is Laura Thomas, Mike Despola, and Carmen Ivaldo. I'm going to talk a little bit about their bio, but before I do, I just want to introduce some housekeeping things. First and foremost, to everyone who is joining us, thank you so much for coming. TogetherWell really appreciates your joining these events, and we love to provide information and support to all of you out there who are doing such amazing work. Because a lot of the topics that we talk about during this time are hard hitting, we definitely want you to make use of our self-care options, which there is a 30-day complimentary virtual yoga and Pilates that you can access from the pad. Definitely look for the link in the chat. Also, there are going to be resources available for you to use that you can link off to also in the chat. And if you have to leave early or leave for any reason, you can access this video on TogetherWell's YouTube channel. At the end of this particular program, and many of our programs, we offer a complimentary meditation. So please feel free to use that meditation if you feel like you need to. It allows you to unwind from some of the topics that we will be discussing. One thing that I want to share with you guys are some statistics about why we believe this issue is such an important issue to be addressing. If you don't know, approximately 128 people die every day in the United States from an opioid overdose. This epidemic by itself has claimed almost 450,000 lives between 1999 and 2018. So just this epidemic by itself, 450,000 lives. That is an astronomical number. Because of the significance of the impact of opioid overdose and just substance abuse in general, it's critical that we start speaking to this and identifying signs and having discussions about what those symptoms are and how they present with our clients. And also understanding how to support them. What do we need to know about the addiction? What do we need to know about treatment options? So we also want to know, how do we manage it in the midst of a pandemic? So our experts are going to be speaking with us about how to handle this complicated issue during COVID in particular, but these are also skills and information that you can take into your practice going forward, pandemic or no pandemic. So I'd first like to start with introducing our speakers, and I'm going to start with Carmen first. Carmen Ivaldo is a senior defense parent advocate at East Bay Family Defenders in San Leandro. She's also a mother of 3, go moms. And I also want to point out that she has a strong knowledge and sharp advocacy skills in her work. She has a personal history with the child welfare system, which has driven her fight to support families. Carmen was the first parent advocate in Alameda County to be promoted into a manager role. Because this was a big change for Alameda County Child and Family Services, they definitely had to develop a strategic plan. So she has been at the forefront of supporting families in her work. And she specialized in training in, and I might mess this up, but correct me if I'm wrong, training in early childhood mental health, as well as FAN level 1 and 2. So she has a significant amount of experience working with families with substance abuse, and she's going to be sharing her knowledge with us today. Thank you so much for joining us, Carmen.
Thank you for having me.
Of course. Additionally, we are being joined by Mark DiCipolla. He's the Vice President of Behavioral and Substance Use Health with San Francisco AIDS Foundation, SFAF for short. For more than 20 years, Mike has dedicated his career to the field of HIV prevention, harm reduction, community-based mental health, and substance use treatment. The approach of his work leans into the goals of health, wellness, and social justice for communities most impacted by HIV, wellness, and social justice communities most impacted by HIV. He's done a lot of work supporting the community and understanding the impact of substance abuse, as well as understanding how sexual health and substance use services can be an important role in their lives. Additionally, he's a member of the Community Consulting Group for the Substance Use Research section of the San Francisco Department of Public Health. So he's going to be coming together with us as well to share his expertise. Thank you so much for joining us, Mike.
Thank you.
And last but definitely not least, we are joined by Laura Thomas, who's the Director of Harm Reduction Policy for the San Francisco AIDS Foundation. Currently, she's leading a massive effort to open supervised consumption services in San Francisco, and I know that she's going to be talking about that with us. She's also been advocating for HIV and public health issues in San Francisco for over 30 years and has since become involved in the AIDS activism through ACT UP in San Francisco. Laura has done a significant amount of work for community-based organizations in San Francisco's Tenderloin community, as well as work for the San Francisco Department of Public Health, and as a healthy policy consultant. So she's going to be sharing her years of knowledge with us about how to support our clients, not just in this pandemic, but also to understand how to support them through the opioid epidemic. So thank you all. Thank you, Laura, for joining us. All right, so let's first start with, how are you guys doing? I just said a whole bunch of stuff, so I just want to check in with you guys to see how are you doing tonight.
Good.
Everyone's doing good. I know that many folks are doing Zooms and whatnot, so
all day.
Being just a tad bit tired from it, I think, is completely feasible. But we're going to make our best of this evening, and I'm going to jump right into questions. And the first question forgive me, I'm having a little bit of a technical issue with loading technology. But let's first talk about what brought you into the field and how the work has impacted you today, particularly with our current climate. So if you can speak a little bit to your role and then tell us how you got into the field, that would be wonderful. And this question goes for everyone. So Mike, we're going to start with you, if you don't mind.
Sure. Just first of all, thank you for having me today. How is my volume? Is it okay?
I think it's good. If you can go a little bit higher, that'd be great. But if not, you're good.
I'm getting a little feedback, but I'm just going to move on. So my role, I'm the Vice President of Behavioral and Substance Health at the San Francisco AIDS Foundation. And it's hard for me to talk because I have background. Could you go to someone else and see if I'm going to try to fix this?
Sure. So if we can jump to Carmen. Carmen, how about you?
Hi, so currently my role is that I am a senior defense parent advocate at East Bay Family Defenders. We support parents that are going through the child welfare system. What drew me to the work is that I'm a parent, I'm a mom, I've gone through the system myself with my own family. I understand the challenges and I understand the obstacles firsthand. And I couldn't imagine doing anything else. You know, honestly, I couldn't imagine. There's a lot of people that are being left behind. There's a lot of people that aren't getting the services that I received, that I was fortunate to receive. And I honestly think that you have to be in it, like a part of the system, in order to change it. I think we have to be inside. So that's what drew me here.
Awesome. And Laura, how about for you?
Well, I started out doing HIV work. HIV/AIDS as a activist, went back to grad school, worked for the health department, and so on. But a lot of what draws me to this work and keeps me here is just the sense of urgency around it, the number of people that we're losing, the friends that I've lost, the family members. And so it feels personal as well as professional to me. And my role, so I do policy work. I work on legislative stuff, on budget advocacy, trying to get, good policies out of, regulatory policies, things like that. So I am not a clinician, I'm not a therapist, but I'm trying to change the world so that the people who we serve can have better lives, and have the lives that they want to have.
Awesome. Thank you. And then Mike, can we try you again?
Yeah, let's try again. Okay, no echo. I could actually do this.
Okay.
So great. I started in HIV prevention, similar to Laura, and also working in care services for HIV. I'm a gay man living with HIV who lives in San Francisco. Came to San Francisco over 30 years ago because I wanted to have a healthy life in an environment, in a community that didn't shame me or stigmatize me as much as I was feeling stigmatized in the community that I lived in and grew up in. My work has intersected around HIV, sexual health, integrated mental health, integrated substance use work for gay men, bi men, trans men, and other communities. And basically, I think the work for me is to talk about things, sex, intimacy, dating, in ways that most environments don't want to talk to people about, right?
Mhm.
So, what are all the things that are unsaid or go unsaid around in drug treatment, around someone's sexual identity, around sexual health, around pleasure, all these kind of things. So, I just want to have real conversations in ways that resonate with individuals so that individuals are willing to come in and partner with us to make changes in their lives. So, how I do that right now, I'm a vice president of behavioral health, and basically I manage all of our substance use and mental health programs for the AIDS Foundation. And our pivot really for us is to try to do services in a way that other inpatient and outpatient programs generally don't. And I still have some feedback, so I'm having a hard time doing this, but I'm going to keep doing it.
Well, you're good so far. I'll let you know if anything.
Okay, it's a little bit challenging when it has the feedback the way it does. But basically, we embrace people and love people exactly where they are. So people are welcome to come in, psychotic, just feeling like they're having a problem with substance use. They don't have to identify as addicts or any other challenges. They just have to feel like something's not working for them. And they're welcome to come in and talk with us. So I'm going to stop there. But basically, I would say that all of our services that we try to create, try to do lower threshold access. So people don't have to answer a lot of nosy questions or do a lot of paperwork or jump through a lot of hoops before they can come in and develop a relationship with us. And that creates a kernel of a relationship from which we can jump off and do a lot of in-depth work.
I think that's fantastic, and it kind of makes me think of the next question. Part of the issue with getting treatment has been stigma around it, and for a very long time in the history of treatment, many individuals who were suffering from substance abuse were villainized or treated as if they were almost like criminal. So I'm curious from all of you, like, what are your thoughts on how we reduce stigma around, substance use as a disease? And, how do we reduce stigma so that people can just seek treatment in an accessible way? And for this one, can we start with you, Laura?
Happy to. I mean, I almost criminalized, but literally criminalized for substance use, right? So personal, drug use, drug possession is considered a crime in this country. And that in and of itself, as you said, like many people consider this a disease, a health condition, and yet we've criminalized it in this country. And I think that that is one of the most important things that we need to do, is decriminalize personal drug use. Like there's a ballot initiative in Oregon right now that is looking at decriminalizing this. And we've got some good things to lean on. The entire country of Portugal decriminalized personal drug use, and they saw really dramatic health impacts in terms of reduced overdose deaths, reduced HIV transmission, increased uptake of treatment. So I know that that's a big ask and that's a heavy lift to decriminalize drug use. I think that it is, who we see as criminals because of their drug use and who we don't see as criminals because of their drug use also have a lot to do with the racial disparities and the lack of racial justice in our criminal justice system. So those things are really intertwined. That's a policy answer, not a clinical answer. But I think the more that the more that individuals are able to speak openly about their substance use, about their mental health challenges, the more we destigmatize it. But I think that stigma is such a huge, huge barrier. And one of the things that we hear a lot from people who use drugs is that they experience that stigma at the hands of the medical establishment and the healthcare establishment. And often it's the people that they are turning to for help and assistance, and instead getting judgment, they're getting stigma, they're getting negativity, they're getting, reported to the criminal justice system in ways that continue to harm them and their families. So, on the healthcare system side, we also have a lot to do to understand how to meet people with as much respect and compassion as possible. Because I think we all know from our own lives, that's when we feel welcome, and that's when we want to come back, right? Is when we're welcomed with respect and compassion and not with judgment and negativity. So stigma it's probably the single biggest barrier, and it goes hand in hand with criminalization.
Thank you for your thoughts. And Carmen, I'm wondering if you can chime in as well.
Laura, I like how you said you used the word compassion. I think really understanding what substance abuse is. I think that just really understanding that. When I think of substance abuse, when I hear that my clients have substance abuse issues, I think that's a symptom. I think that's a symptom of what the core issue is. And so I want to dig deeper into that. And really also trying to understand, when you understand that, then you'll understand what the urge to use is. At the CWW, I was in a CFT last night, 2 nights ago. And the social worker had said, they were really, really about to remove, and she almost said something along the lines of, if she wouldn't get high, if she just wouldn't use, we wouldn't have this problem. You know what I mean? That was kind of like her message. And for me, it's I think that even if she didn't use, there would still be a problem. I think that there's still an underlying issue here. I don't think we're asking the right questions.
Awesome. I love that you're pointing out that this is a symptom and that there are larger issues as well that are at play. I think it's really important to kind of delve in and do that work. And Mike, I'm wondering for you if you can add to what both Laura and Carmen have shared.
Yeah, I guess I would first start. Am I getting audio? No?
No, I can hear you.
Right.
You're good.
Right. Sorry. Where I would start is basically, I just want to support what Laura was saying. I have the shirt on that I have on is No More Drug War, and I have it on today on purpose for this conversation, because I think that it's very important to look at how prohibition and our relationship as communities with substances impact how people address or don't address how substances are working or not working for them. And so I think we should start and kind of change our language and look at how we change our language from the perspective of, I think that people use substances either to feel good, feel pleasure, or to get away from feeling certain things, to medicate, right? And we have to value that it's okay for people to feel good and feel pleasure. And if people want to use substances to do that, we have to help them understand how they might do that and be successful in their lives. If people are misusing substances or having problematic substance use, we could also be available for them to talk about those things as well. So substance use conversations are just not simply about if you're struggling with substances. It's also about how to make substances work in your life. And if substances are not working in your life, what is going on with that? And how can we help you make improvements? And we also have to be very careful to be focused on what is the end goal and who is the end goal for. In substance use and substance use treatment, oftentimes the gold standard is abstinence. Well, that is not necessarily something that somebody is interested in. Maybe we have people that come in and want to do abstinence, maybe we don't. But what we really need to do is explore with them what is right for them. So when we think about destigmatizing, we have to first think about how do we accept into treatment or any conversation about substance use anyone, regardless of whether they define or they see for themselves that they have a dependence or abuse issue, right? That we welcome people in at any point along the drug and alcohol continuum for any reasons. And if people are ill and they're really struggling, that we get over ourselves in the drug treatment world and we allow them to come in and be sick. And we don't create so many barriers to treatment. For example, you have to have 30 days clean and sober before psychiatry sees you. You have to answer 1,500 questions before a counselor will talk to you. These kind of things. We have to find ways to be able to embrace people coming in to talk and have conversations with us that are very deep personal conversations in ways that resonate more effectively with our populations. So, and then in terms of stigma, we need to create environments that are welcoming, but we also need to train everyone from the folks at the front door to the security guards, to everyone that is in the building on trauma-informed care and how to not stigmatize or shame people that come in and may look sick. I'll stop there.
No, I think it's fantastic because, the reality is working on people not being judgmental. Kindness goes a long way. And as a clinician, I think it's really important that one of the things you pointed out is not jumping to the immediate idea that abstinence is the way to go. That's not necessarily what everyone is looking for, and being more exploratory in terms of treatment and what the patient's goals are. So I think that too is a very big piece of the treatment. Like, I think a lot of clinicians have an expectation that once you're coming into treatment, it's only for abstinence, not necessarily how to use a substance effectively in your day-to-day life, which many people do with medication, prescribed medication. And that's something that we have to think about. Substances aren't necessarily alcohol and cocaine. There's Adderall, there's other prescription drugs too that are being abused in terms of opioids. So I think we're talking about a lot of different complexities to this issue. And Carmen, if you could speak to what you feel are some of the complexities regarding interventions in the community.
I see a lot, I experience a lot of different complexities. I think, just the revolving door of services, that change like week to week. And the steps that we have to take in order to get somebody support. I don't necessarily, lack of funding. I think also it's also internal. I'm in recovery myself, and so I'm really hip to this in the community. Is like, it's not just inside our community. It's like a whole economy. Like substance abuse, how people make money, how people come up, status. It's just, there's a lot of complexities, and it's so much deeper, than just having the resources, than just having the funding, than just. I'm just trying to put this in a really gentle way, but it's a lot deeper than that. It's a culture. It's in the whole. It's a community. It's a culture. It's got its own economy, and then what? To give that up, it's asking a lot. So,
especially, I think what you're pointing at too is if this is a means of survival.
Right.
I think that's a significant ask, because most often we're asking to take something away, not necessarily replacing it. So I think what you're speaking to is super important. And I imagine that there are all sorts of questions that come up regarding how do you deal with the complexities? What do you do? So I'm curious, Laura, if you can speak to what some of the questions are that you are frequently asked.
Just to pick up on that last comment, one of the sort of grandmothers of the harm reduction movement in this country, Edith Springer, she always had a thing about don't take something away if you're not going to replace it with something else. Like, don't take something away, something that has been a survival mechanism for somebody, either in terms of managing their pain or economically or something. Don't take that away without providing them with something else to take its place, because otherwise you're just taking things away from people, and that just adds to their trauma, right? Instead of being able to say, maybe this is a better way of coping with that, or maybe this would work better for you and your family, or maybe this, you know, would you like to try this, right?
Right.
So yeah. Go ahead.
No, I just think that's fantastic, because it is very true. And also, I think not just replacing it with what, if you're a clinician or even a politician, with what you think is the best way, but actually getting the input of the client we're working with and looking at some options and trying things out. I think everyone's pushing for a quick fix, and often there aren't any. So it's the time. But I imagine, as someone who's doing a lot of work in policy, there are many things that you're being asked, and how you're going about it. I'm just wondering if you could speak to that.
Yeah, I feel like in this country, we've done such a bad job of educating people about the realities of drug use, both of why people use drugs, what drugs are, as well as how people develop problematic relationships with drugs, and how people get out of those problematic relationships with drugs. So I get asked a lot of times these really, like, just not fact-based questions that come from people watching, celebrity TV shows or things like that, where they're taught something and they think that's true. And it's just, we do such a bad job of educating young people about drugs, and then it becomes, people in positions of power, and they also don't know much about drug use. And so I think some of it comes up with these ideas about, there are some drugs, if you do them once, you will, like, inevitably, like, be lying in the gutter with no teeth, sort of thing. And that's just not the reality for any drug. Like, the majority of people who try any drug don't develop a problem. But we make policy decisions based on the people who do develop problems. And so that becomes part of what happens in the policy sphere. For this idea that, again, as you said, abstinence is the goal, or that forcing people into treatment will when in fact so many people that politicians look at and are like, why isn't that person in treatment? That person may have been trying to get treatment over and over and over and over again, and either they can't find treatment that allows them to stay with their family, or they can't find treatment that allows them to keep their job that's needed to keep their family in housing, or they can't find treatment where people speak their language, or they can't find treatment where they're feeling respected and taken care of. And so, or they found treatment and then their health insurance changed, and then they had, right? So there are all of these ways in which we have this idea that people should be in treatment, or we have to push them into treatment, or we have to arrest them in order to get them into treatment. And those are just such wrong sort of understandings, that we wouldn't treat any other health condition like that, but somehow we think it's okay. So those are some of the, just tackling those kind of misperceptions and misunderstandings about substance use, that I feel like those are things that come up a lot for me, and that I find really frustrating, because I'm like, I'm not necessarily a drug educator or a health education person, and I'm finding myself having to, some legislator who just saw some TV show and now they got this in their head. So we want more science-based education for young people and older people too.
And with that, I'm going to ask one more question of you. And if you could speak a little bit to what you know about the research in harm reduction, and then I'm going to tie it all together with everybody because I have a couple more questions. But I think that because you're speaking to how people think treatment should be done, harm reduction is a particular model that has been effective. And I'm wondering what your thoughts are on the research and related to harm reduction.
Yeah, and Mike can speak to this as well. But I think it works best when we think of harm reduction and treatment as part of one continuum, right? So it's not necessarily an either or. And many people in their individual lives can access harm reduction services at one point, access an abstinence-oriented residential treatment program. They might find that, 12-step programs work for them at a certain point. They may end up back at harm reduction programs at another point. But you can have a full continuum of services, and it can include harm reduction, low threshold. It can include more intensive interventions. And so a lot of it is it's this sort of false dichotomy. Harm reduction is over here and treatment is over here. Harm reduction encompasses a whole range of different interventions, but it's really the same philosophy that has us wearing masks when we go outside and social distancing, and we're going to continue to be human and have to go out into the world, but how do we do that most safely right now? How do we reduce the potential harms of COVID-19 in the world? We wear masks, right? How do we address the potential harms of drug use? We can provide sterile syringes. We can provide naloxone to reduce overdose. We can provide supervised consumption sites, things like that. So each of those interventions has been extensively researched. So syringe access has, decades of research behind it. Naloxone distribution to prevent overdose deaths has decades of research. In part because these things are sometimes controversial, we often end up with a whole lot of research, more research in many cases than we have around the efficacy of 12-step meetings, for example. The research has shown again and again that the programs reach the target populations, that they improve health outcomes, and in many cases, they serve as a link into other types of treatment as well.
Amazing. So I love that you gave us kind of very high level description. And I'm wondering, Mike, if you could speak to, harm reduction in practice. Because sometimes I think the practice level versus the research can look very, very different. And I'm wondering two questions, what you wish people knew about your work, and then also about your thoughts on harm reduction as a model.
What was the first question? I missed that.
If there are particular things that you wish people knew about your work, and then, just your thoughts on harm reduction use in treatment.
Yeah, I think the one thing is I think treatment community overall needs to stop stigmatizing different ways of looking at the problem. When you think about harm reduction is a philosophy. And basically, harm reduction values all different opportunities that one wants to use to be able to look at how drugs are working or not working in their lives. Harm reduction is as simple as looking both ways before you cross the street, right? So basically, it's any step that someone wants to make to improve their health and wellness. When you think about harm reduction in a treatment environment, I basically do harm reduction based or focused treatment services and pre-treatment services and early engagement services. So we use the philosophy of harm reduction throughout our continuum, similar to what Laura was talking about, was anything from street outreach to actual drug treatment can be done from a harm reduction lens. And what does that mean in terms of what does that mean in practice? It means that if someone comes in and they have no intention to be abstinent, or maybe abstinence is not even the right choice for them, they can still come in to treatment and actually make changes in their lives that are just as valuable and important to them than the gold standard of abstinence. I think if we stop looking at the gold standard of the abstinence as the only success, then we can look at all the other levels of success that someone can make. When you think about treatment in the realm of harm reduction, for me, we put it together in basically a model of three. It's substance use management. So we help people look at how they can manage substances in a way that works better for their lives. And let's say, for instance, we have someone who's injecting daily. You can imagine all the harms that someone may be experiencing if they're injecting daily. So some of it could be an easy conversation as much as how much are you loading in your rig, when are you using, what problems are coming up, and how could you do that in a way that those problems would not come up, right? So that's so substance use management could be anything from I want to use as much as I can get my hands on to I want to use once a year during certain holidays, right? So we could accept people who want substance use management. We could accept people who want to abstain from one or more and use others, and we call that targeted abstinence. So they want to abstain from one substance but not others. And then we could work with people who want to do full abstinence. But when we do it in a harm reduction lens, even if we're doing full abstinence as a program, we don't kick people out or demonize them if they're struggling to meet their goal. What we do is we look at what steps might that individual take in order to work towards their goal, and what may be preventing them from the goal, and also is that the right goal for them right now? Similar to what Laura was saying, if, for example, we have someone that comes in and wants to do full abstinence, but they've been using for 20 years, they have very limited coping systems, they have very limited social support, they're not housed, then we look at how can we start peeling back and creating some levels of success so the person can feel like a valuable person who is powerful in their lives and feel like they have some mastery and they can continue to make success in their lives. So what happens is if our participants think the only standard is abstinence, then that puts them immediately in the negative column because they're not good enough for these types of programs. And what I say is, if we are failing people out of programs, it is not people that are failing out of programs, it is programs that are failing people. And when I sit and talk with somebody, honestly, who wants to do substance use management, I have seen vast improvements on all kinds of levels. But one thing I would say for people that are detractors from this model is some people say, well, how could you sit and have a conversation with someone about how much they're loading in their rig? That's irresponsible. Well, what I say first off is dead people don't get better. And secondly, I've had these conversations and my team have these conversations every day. And what happens is when someone comes in and they don't feel stigmatized or shamed, they can let their shoulders down. They can exhale. They can feel like a valuable human being. And it gives them space to think for themselves, is this working in my life and how is it not working? And then they have space to really, they have more space to explore outside of that shame spiral. Because when someone's feeling shamed or they're feeling stigmatized, or they're feeling like the person that's working with them is stigmatizing them or telling them what they're doing is wrong, the work's not going to go anywhere. So we have to what I'm saying is as providers, we have to get out of the way. We have to be willing to get out of the way. And what I say to people that are looking at this model, and I'd be happy to talk more in depth about how we do this, but the first thing is, in order to do this, it takes providers a high level of courage to sit and hear what's going on really in a person's life. Because sometimes when someone's struggling, you have to watch them unravel. And you telling them to stop or forcing them to stop is not going to get them to do it any more fast than if they come to it themselves. So I think these are the important conversations that we have to trust and love people enough to walk with them in a partnership. Not, when I think about a substance use treatment, I have expertise, but I am not the expert in the room. The participant is the expert in the room, and I am there in partnership to help explore what's going on in that person's life and to love them unconditionally, regardless of what kind of struggles they have. Now, of course, the one thing that people say about harm reduction as well is that we don't tell people lies about what's going on. If someone comes in and they're injecting every day and they're always in the emergency rooms and struggling immensely, then we will talk with them about, hey, this doesn't seem to be working. What else do you think might work? What else might you be willing to do? And then we help them explore what might be some things they could do if they're kind of stymied by it that might improve some of the factors they're struggling with. I'll stop there.
No, I think it's a fantastic point because you're speaking to the fact that you're working with someone versus trying to change them. And it's a very common expectation that someone should just stop and move on. And I love the fact that you're pointing out to the collaboration in the treatment. And I'm wondering if just thinking about that and thinking about Laura's role and Carmen thinking about your role, I can imagine there being pushback if, for example, Carmen, you're in a meeting with a social worker and the issue is about potentially removing a child from a parent because they're using substances or they're in treatment, but the treatment isn't looking like what like if it's a TDM or a team decision meeting or something, like
Yeah.
the team's not expecting that this treatment should include any substances. So kind of thinking, Carmen, if you could just speak to, the idea of someone being in treatment and working towards treatment and how that might pop up in a social work setting and how you might support the family or the client.
That's a really difficult question. Michael, I'm listening to you, and I wish that I worked in a system that had that much room,
Yeah.
that much space, because unfortunately they don't. They're in a system that, and they have a lot to lose. You know what I mean? Like they have their children, that they have to lose. And so the system doesn't have a lot of space for that.
Well, and that's where I would say, like, Carmen, sorry to interrupt, but I think that's where like systems like yours could partner with other systems that are doing lower threshold or other types of services. And often for us, for example, with the work that I'm doing, we partner oftentimes with other systems that are a bit more closed and their goals and objectives are a bit different, so that we can do some of the work that you cannot. And I think those partnerships are critically important, because if, for example, Carmen, you're working with someone who cannot or is not ready to stop yet, but they can make huge improvements in their life, and maybe they can work towards reunification, we can partner with you to actualize that, And I think what we haven't talked about, I also think, is that the funding mechanism here that's connected to this. The type of work that I'm doing oftentimes is not funded by the government. It's not funded by Medi-Cal. It's not funded by a lot of health departments, although it is funded locally by the San Francisco Health Department. Many health departments don't fund these type of interventions. And I would say that the funding for us comes oftentimes through HIV prevention, through HCV prevention, through other disease prevention mechanisms. That's one of the mechanisms that allows us some funding to do some of our services that we do. But Carmen, I just think that if you're open to these ideas, then I think it's important for you and for others that are on this call to think about how can you find other organizations to partner with, so the work can be done in unison with individuals to move towards a goal that makes sense for them.
I think that's a great point. And in some ways, I feel like that should also be part of policy, because we have all this great research. So if we know exactly how to blend the two, then maybe we look at that in relation to where the grants go and how this is added in an additive, supportive program in addition to, working with children and families with substance abuse. We have, this lower threshold treatment model too that we're incorporating. And I mean, there's so much wonderful information here, and I'm also looking at time, so I'm going to quickly kind of jump to a couple more questions before we wrap it up. One thing that has been in the news, in and out of the news, that I think has had people up at arms from time to time is the issue of safe use sites. And I think in one article I was reading about Starbucks training their staff on how to use naloxone because often they have opioid overdoses there. Not as big an issue right now in COVID, I'm assuming, but just thinking about that. So I'm curious about your thoughts and ideas on the use of safe use sites. Do you guys feel that it's enabling? And Mike, I'm going to start with you, and then Laura, if I can have you chime in as well.
So I would say every door is the right door. And the fact of the matter is, I want to work with people who are injecting or are smoking or using substances. And I feel like, one of the things about a supervised injection facility or safer consumption space or overdose prevention centers, they're called many different things, is that, no one has ever died in any of these environments before. And that's critical. And I think that when we think about these type of environments, we think about an integrated model where people can get education, information, learn how to inject properly so they don't injure themselves. If they have infections, those infections can be treated. They can get STI tested. They can get HCV tested. They can get on HIV meds if they have HIV. So all of these health services that help, like, for example, if someone has untreated hepatitis C, they may be feeling so awful, and they may be treating some of the symptoms of their HCV by using more substances. Being able to treat their HCV could be life-changing for them. And we've had that experience through our syringe access services. So I think the reality of the matter is we have to be careful about being afraid of working with people in all these different intersections. The reality of the matter is, in all of our urban centers across the country and across the world, we're in a crisis situation. And we have to be willing to try things that we're currently not doing. And when you look at the the recommendations from the Methamphetamine Task Force from San Francisco, that was in 2017, well, 2019, and the Supervised Injection Services Task Force recommendations, which are on a website, and I can send you the link. All of those recommendations were about creating more environments that accepted people where they were in a walk-in environment. And that's what these type of centers would do. And they would hook people up to housing, to case management, to medical care, all of those type of things. So I think the question for me is not should we do, we have to do, we must do. It's the question of how can we gain the will from a public policy perspective and a political perspective to do this. And I think some of the answer there is all of us on this call and many of us who are listening that I can't see their faces probably have family members who have had substance use or misuse issues in their lives. Would any of us want our family members to be injecting in alleys? Would we want our family members to die without someone there to assist them? And that's what we're talking about here. What we're talking about is having the humanity to open our doors and to do treatment in a way. And when I say treatment, even for me, a supervised injection facility, even if someone's just coming in to inject, that is an opportunity to create a relationship. And that's the kernel of every moment of change for each person that we can touch. So I think we have to have the will. And I think that, Laura Thomas can speak more to this, but I am definitely an advocate for this and it has to happen.
Awesome. Thank you so much for your thoughts. And Laura, can you share your thoughts as well?
Yeah, I mean, part of what's been happening during COVID, people may not be using Starbucks bathrooms, but they are overdosing. The numbers in San Francisco have been skyrocketing since shelter in place began. Naloxone reversals have jumped. There are a lot of reasons behind all of that, but overdose, this is going to be the worst year ever for overdoses in San Francisco, already just 9 months in, and we're already seeing probably triple the number of deaths that we saw last year. And it's, and the racial disparities are really bad when you look at the numbers. And I posted the Supervised Injection Services Task Force in the chat, and I'll post the most recent substance use report. But the disparities, particularly for African Americans, are so high for overdose deaths, and they've only gotten worse in this past year. So, urgency is real, and we need to be stepping forward and saving people's lives. We know we could be, and we're not doing it. That really, it's about political will. So one of the things that I've done over the last few years is I worked on a series of state legislative bills. The one didn't come up for a vote this year, but State Senator Scott Wiener from here in San Francisco has already announced that he's going to be introducing a new bill for the legislative session that starts in January. And so we'll be working closely on that. And we always need support for the legislation. And the legislation as it's currently drafted would allow San Francisco or Oakland, which are the two localities that have expressed interest in doing this, to authorize pilot sites and evaluate them. Any of these sites, it's essentially like a syringe access program, except you're also, instead of telling people, okay, there's the door, you're saying, okay, now come in here and you can use in sterile conditions, use your substances with staff who are trained in overdose reversal. And many of these programs also, the ones that exist in Canada, for example, also have, they've got clinicians on site. So there's a nurse to look at your abscess. There's a doctor who can prescribe Suboxone right then and there for you. There are people who can, as Mike was saying, like start your Hep B treatment right then and there. Being able to offer those services with people who are feeling, again, respected enough that you're allowing them to be present in their whole selves, including using drugs. So it's been effective as a way to get people into treatment and for people to stop using drugs. It's been effective at reducing the number of syringes that are improperly disposed of or people injecting in public. It's been effective at reducing overdose deaths, absolutely, and reducing HIV and transmission. So I think it's just a necessity given the urgency around overdose deaths right now, at least here in San Francisco.
Thank you so much for that. And I am just thinking currently with how we are living in the situation and everything that both you and Mike have shared. Carmen, I'm wondering if you could speak just a little bit to what you think the families who are experiencing this right now can use from, you know, from clinicians, from child family services. Like, what is it that you would hope that they are able to access to support them?
What is it that I hope that they could access? I think I would hope that they could access exactly what we're talking about here. And that's, you know, compassion, that is, you know, being open-minded. I would want them to be able to be treated like as humans. And, you know, and some of the challenges, you know, and that's what the challenge is, that they don't get that.
So it'd be amazing if we can just send them to Mike and or have Mike build a team for many of the families you're working with.
Absolutely. Absolutely.
Yeah. And I feel like, you know, that women, pregnant people, families often get the worst of the policies when it comes to drug use, that it's hard enough, you know, walking through this world as, you know, as a woman, as a mother, as a parent, as a person of color, especially as a woman of color. And the ways in which we have so many systems designed to set people up for failure, you know, whether it's about, you know, charging a pregnant woman with murder for a miscarriage, right? Because she had a positive drug test at one point. Like, these are some of the worst abuses of the war on drugs, in my opinion. And it's, you know, if figuring out how to improve the supports for families, for women, for children who are living in families where there's substance use, you know, I mean, we know that we need multi-generational cycles of trauma, and we're not providing families with the kind of support that they need to get out of that. So I have huge respect for the work that you do, Carmen. You know, when you say there's not space in your system, that's so true. Like, and there's a reason, and it's because we haven't been valuing women, we haven't been valuing families, we don't value children. So we're not allowing any of that space there. So I'm hopeful that we can get to a place where you have all of the space and all of the resources and all of the time to be able to make changes in the lives of the families you work with.
So in the interest of time, I'm just going to ask one quick question. In terms of the work that you guys have been doing, because you've been on the front line and putting a lot of time, energy, and your soul into your work, what are you doing? If you can name at least one thing that you're doing to take care of yourself. And this is open to anyone who wants to jump in first.
I mean, for me, it's trying to maintain connection. I mean, that's so hard, and it means that I'm on Zoom all the time, but just trying to maintain connection with friends and family and community members. And then, as I disclosed to folks earlier, I've got my cat right here on my desk next to me, and that is helpful.
I guess I want to say that doing this work in the time of COVID is harder. And the crisis around overdose is getting bigger, and I think a lot of people, including myself, feel a lot of pressure about that. And you know, locally, for example, the Department of Public Health is constantly calling us up and asking us to partner on new initiatives because we're trying to kind of get at some of these intersections where people are falling out. And I guess, you know, the reason I'm answering like this about taking care of yourself is that I have to be careful about not taking on too much, about knowing that this is a crisis, and at the same time knowing that the period of COVID, this crisis is hard on me personally as a human being. I have family members in my life who are ill. I have friends who are struggling. There are times that I struggle, right? And I also have to appreciate that and know that from my staff and my teams, right? So I have to kind of be careful about how much I accept as an individual and how much we accept as a team that we could take on, and make sure we take breaks. And then personally, you know, my big thing is I need to get outdoors and I need to exercise. You know, for me, exercise is my meditation. I'm kind of an extreme sports kind of person. And I need to do something extreme to get my heart pumping. And I try to do that as often as possible. And I have to say, with COVID, when the fire started, it was devastating to me, because not only could we stuck in our homes, but then we couldn't even go outside and exercise because the smoke was so bad. So, this is a sustained period of crisis for all of us. So I think the bottom line is be kind. I try to be kind to myself, and I try to be kind to others, and I try to recognize when I need a moment to stop. And honestly, that makes me feel bad about my work sometimes. And I have to be careful about that, because right now I need a lot of moments to stop, and it makes me uncomfortable, but it's the reality for my life.
Thank you. And Carmen, how about you?
I mean, just simple little things is, I enjoy a really good cup of tea, when I need it, like that just does something fabulous for me. I cry when I need to cry, and I recognize that I let that happen. I be as involved with my children as possible, and just like really try to enjoy them, and laugh with them, and just kind of like be silly with them. And then, big things. I love to travel. That's like just the cover through this whole thing. It's just really difficult to do that. But soon.
Well, hopefully everyone will be able to develop a new normal by not being required to shelter in place so much, and slowly we're moving into that. But I definitely want to thank all of you for participating, because this has been such an informative segment, and I really appreciate all of the information that you've shared. I also want to just highlight, I think some of the most important pieces of what you've shared is create a caring, compassionate, empathetic, and open environment for your clients, and to come in and be their full authentic self, no matter where they are in their treatment, and not necessarily jump to abstinence as the end goal, but to hear them out and think about, alternatives and ways to get to a goal, whether it's targeted abstinence or full abstinence, as Mike has shared. So, and also just being present and taking time for yourself, because the work is hard, and being also very much involved in legislation if you can, getting out there and voting for what we need and sharing your voice. So again, I want to thank all of you for joining us and for sharing your thoughts. And we are going to stop here, and we'll be joined with Dr. Costella shortly.
Wonderful. Thank you.
Thank you. Take care, everyone.
Bye.